Welcome everybody. Let me present my PhD projects on hemodynamic management in the perioperative period of non-cardiac surgeries. I'm Zsuzsanna Weber. I'm a PhD student and also a resident at Semmelweis University, Department of Anesthesiology and Intensive Therapy. My vision is standardized yet personalized patient care worldwide, and my mission is to help create high-quality evidence-based strategies while being effective in patient care. I have two projects. The first one is investigating the safety of continuing renin-angiotensin-aldosterone system inhibitors for non-cardiac surgeries by meta-analysis. The second is investigating the efficacy and safety of multimodal individual hemodynamic management in patients undergoing major abdominal surgery, and this will be a study protocol for a randomized controlled trial. Let me start with the first project. The problem is many patients undergoing major non-cardiac surgeries have hypertension or chronic heart failure, and antihypertensives such as angiotensin-converting enzyme inhibitors and angiotensin receptor blockers usually play a key role in the treatment of these conditions. And because general anesthetics also have blood pressure lowering effect, we know that continuation of these drugs can lead to hypotension, causing deadly complications. But on the other hand, discontinuation of these drugs can lead to hypertension, and it is uncertain whether withholding them actually reduces hypotension-associated complications. The guidelines are inconsistent. For example, Japanese guidelines suggest withholding them on the day of surgery. Canadian guidelines suggest withholding them a day before surgery. And the ESC guidelines have different recommendations for patients with or without heart failure. And also, you can see that the class of recommendation and the level of evidence is quite low in case of these guidelines. In order to improve recommendations, we chose to investigate whether continuation strategy is the safer approach or not. The clinical question is if continuation of renin-angiotensin-aldosterone system inhibitors is the superior strategy for reducing complications in patients undergoing major non-cardiac surgery. We use the PICO framework. The population of interest is patients treated with RASes undergoing major non-cardiac surgery. The intervention is continuation, and the comparator is discontinuation of these drugs. Our primary outcome is mortality. Secondary outcomes are major adverse cardiac event, hypotension, and acute kidney injury. We conducted the systematic search on 3 databases using this search key consisted of 3 domains. And following the Prisma flowchart, we started with 5,099 articles and ended up with 21 eligible articles. We're done with the data extraction, so I can show you some results. This figure compares the 30-day mortality between the continuation and discontinuation group. While 30-day mortality is important compared to, for example, in-hospital mortality, it's because many adverse events may occur weeks after the surgical procedure. We included 7 articles into this analysis, from which there are 4 randomized controlled trials and 3 non-randomized studies. As you can see, we have subgroup analysis based on the study type. The I-square shows that we couldn't detect heterogeneity due to the low number of studies. But if you look at the study types and the patient numbers, it's clear that there is high heterogeneity. And the results is expressed as odds ratios. It's 0.93 in favor of continuation, which means that the 30-day mortality rate might be lower in the continuation group, but this number is not statistically significant, so further research needs to be done in the topic. With acute kidney injury, which is one of our secondary outcomes, it's also important because this can be caused by hypoperfusion. We included 8 articles into this analysis. There are 4 RCTs and 4 non-randomized studies. And with the heterogeneity, it's the same issue as with the mortality. And the result here is expressed as odds ratios 2. It's 1.06, suggesting that acute kidney injury might occur less frequently in the discontinuation group. But it's, again, not statistically significant number, so further research needs to be done. Let's move on to the second project about multimodal individual hemodynamic management. The problem is anesthesia is safe, but high-risk surgeries are still associated with postoperative complications. And even though only 10% of the surgical population is high risk, that 10% is responsible for over 80% of overall mortality. We know that intraoperative hypoperfusion increases the risk of postoperative complications. Therefore, adequate hemodynamic monitoring is crucial. The most often used monitoring for a standard risk surgery includes heart rate measurements, ECG, non-invasive blood pressure monitoring, and pulse oximetry. This is what we call a routine monitoring. In case of high-risk surgeries, this can be supplemented with the measurement of central venous pressure, invasive blood pressure monitoring, and pulse pressure variability measurement. In such cases, we are talking about advanced hemodynamic monitoring. Multimodal hemodynamic monitoring gives us even more information. For example, cardiac output, stroke volume, central venous oxygen saturation, etc. And if we put these parameters in the context of the given patient, given time, we could do personalized care, or in other words, multimodal individual hemodynamic management. The whole purpose of the hemodynamic management is to avoid hypoperfusion and keep balance between oxygen delivery and oxygen consumption. In case of individual hemodynamic management, the method for achieving this goal includes putting all these parameters into, again, the context of the given patient and given time. And even though strong pathophysiological rationale supports this method, clinical evidence is lacking. And given that it's a very complex, time-consuming method, its efficacy and safety cannot be guaranteed based on only pathophysiological rationale. In order to clarify whether we need this very promising but very slippery method, we need to perform a randomized controlled trial, for which the clinical question is if multimodal individual hemodynamic management reduces postoperative complications in high-risk patients. We use the PICO framework. The population of interest is high-risk adult patients undergoing elective major abdominal surgery. The intervention is multimodal individual hemodynamic management, and the comparator is conventional care. The outcome is a composite outcome of postoperative complications as defined by a highly impactful paper from Salzwedel. Our hypothesis is multimodal individual hemodynamic management is superior to current standard of care in reducing postoperative complication rate. You can see the feasibility schedule here. As you see, we have adequate material and financial conditions, adequate human resources, and the next step will be the sample size calculation. In summary, I would like to finish the first project by the September of 2025 and the second by February 2026. Let me finish the presentation with a quote from Erykah Badu. The man that knows something knows that he knows nothing at all. So let's not settle for what we believe to know, but keep on discovering and learning. Thank you for your attention.
I just had a question about the other medications that these patients may be taking in your first project. So are there any medications that might interact with RAS inhibitors that could be relevant and influence the outcome?
Yes, it's a very good question. Not really the interaction, but other antihypertensives. Many times the patients who are investigated, they are on diuretics, calcium channel blockers, and this causes heterogeneity, of course. And in the future, it would be good to do subgroups for primary studies, but they don't really do that, unfortunately. Yeah.
You mentioned that 10% of patients are high risk, right? And how are those patients different from the 90% of other patients from an anesthesiology point of view?
Well, high-risk patients, there is the patient part and the surgical part. So the patient part is the comorbidities that they have. We can classify them based on the ASHA score. So I would say over 2 or 3. And the surgical part is like considering the blood loss that we accept, how long it is, if it requires an overnight stay. And from an anesthesiological point of view, for older patients with heart failure, hypertension, they usually need less anesthetics or even different kind of anesthetics for both induction and the whole procedure.
Concerning your first study, you mentioned the comparator arm is a discontinuation of treatment, right?
Yes.
What's the mean, or did they report the medication-free interval prior to the non-cardiac surgery?
Do you mean
why I'm asking this, because in some situations, surgical stress can trigger a rebound reaction, especially with RAS inhibitors.
Yes. So your question is when they give the last dose?
Yes.
It's a very good question. I'm lacking it too. They have in their protocols they say that they discontinue it, for example, 24 hours ago. But sometimes it's not very obvious what they mean about it. Like, do they get it 24 hours before the surgery, or they would get it 24 hours before surgery, but they don't, so then it's plus 24 hours. But sometimes they are more precise and say that the last dose is 48 hours before surgery or 24. And some articles even take the pharmacokinetics of the drugs into consideration and have different recommendations for different drugs.
The deepness of general anesthesia shows a strong correlation with hemodynamics. I mean, the stability of the hemodynamics. What do you think about to standardize the general anesthesia with anesthesia deepness monitoring, for example? Has it relevance, for example, in terms of your study?
Yes, actually, in the second project, this would be the part of the multimodal hemodynamic management that we monitor the depth of anesthesia. So we just got the new monitors and we learn how to use them. So definitely, yes.